So you've been listening to a lot of tech, and it's time for you to get down to the grassroots, which is what we do. I represent Biocon Foundation, and we have several verticals in which we work. We're into rural development, where we build schools, toilets, and even roads in villages. Then we're big into environmental sustainability, very topical for Bangalore because of our dying lakes. We have always been in healthcare and always tried to innovate. And the education program is where I came in a big way. Those of you who can read Kannada, you can read the title of the book, Chinnara Ganita, which is a self-help, mostly pictures and very little words and a lot of fun in maths. When we talk about healthcare, I think it spans all these four verticals. Because when we do rural development, we are doing sanitation. In environmental sustainability, we are concentrating on providing good, clean water, which is also what we do in rural development. We set up RO plants. Healthcare, I will be talking to you in much greater detail. And education, we have adolescent girls' health programs, and we are going to start a new program in health. We want children to be more aware about how to monitor blood pressure of their family members and be more conscious about what hypertension can do. So when I talk about our projects and our programs, I hope that you will see that in all our programs, we try to bring in innovation in terms of devices, in the way that we deliver the service, and primarily to develop a proof of concept and showcase it to the government by implementing it in a government school or hospital or any other government-related organization, so that they will take that proof of concept and scale it. In order for them to scale it, we have to make it look very exciting, because now we have a whole new breed of administrative officers who are big on technology and would like to be known for bringing something new into the department when they leave it. Also, we have to show that it's affordable, because otherwise the government can't scale, and definitely impactful. So our flagship programs are in lake revival, in primary health care, and early detection and treatment of oral cancer. The quotation that you see there is by Franz von Houten of Philips, the CEO of Philips. And this wasn't particularly, I didn't go looking for a quotation from him, but when I did look for a quotation on healthcare, I found that his were most meaningful and so very relevant. In fact, I almost felt that he was looking over our shoulder as we were designing our programs. So this is a picture not of Amsterdam or anywhere in Europe. It is in Yarandahalli, which is Anekal Taluk. And believe me, it didn't look like this a year ago. This is the Hebbagodi Lake, also rejuvenated recently, over a year. And the success that we've had in lake revival is because we have innovated and used 3 different approaches. Bioremediation, we dose the inlet. As you know, all the lakes are being infiltrated with sewage and effluent. So wherever the inlets come in, we dose it with enzymes and microbes to break it down into harmless water and harmless gases. Then we build our own floating wetlands. Our floating wetlands have canna and vetiver grass, completely fabricated in-house In fact, to make the whole structure float, we raised a campaign in Biocon, and we asked everyone to donate their 1-liter plastic water bottles. And we just put them into pipes, and we made the whole structure float. We planted some canna and vetiver, and those absorb the sulfates and nitrates from the water. And of course, the aerators to oxygenate the water. And if you come, I invite any of you to visit Hebagodi Lake in the evening at about 6 o'clock, and you will see a variety of birds. They've even started nesting in the cannas. So this is what the lake looked like in 2017, and this is what it looks like now. A big thank you to the Biocon Central Engineering and Environmental Health Services teams, not to the Biocon Foundation team. We just bask in their glory. This is a perfect example of employee engagement. No photo ops, complete dedication. They take up a project as if it is as important to building the industry and make it work. So now we come to the brass tacks, innovation in primary healthcare. We were looking at starting small clinics in rural communities which had no access to healthcare. And we did so in several villages. So we had 8 primary healthcare clinics to begin with. But then we thought it's time to scale, and the only way to scale is to go with the government. So we set up, or we designed what we call the E-Large Smart Clinic. E-Large means cure, but E-Large includes the technology, okay? We have E-enabled the healthcare. So on your left, you see the workflow, and as I was just saying, the quotation just matches it, as if Franz von Houten was looking over our shoulder as we designed the E-Large program, because he says, better integrate workflows and technology so that the care experience is seamless and provided at the location where it makes most sense. So it is there in the primary health center of the government in the remotest rural areas. A patient comes in, and we provide a laptop and a registration desk data entry operator who puts in all the patient details. And we have a device which is a multi-parameter device. And we are looking to Philips perhaps to produce something which is completely innovative in this space, because we are having problems with our multi-parameter device. It doesn't work at high temperatures. So it doesn't work well in summer. It doesn't work well when it's outdoors, primarily because the glucometer is very sensitive to heat. But, so in many places, we give them a glucometer on the side so that the process doesn't stop. So the patient, after being registered, instead of simply sitting on a bench and waiting and waiting and waiting, gets at least all these things monitored. And this is done the first time of registration. And we give them a little card with a number. The patient then gets to see the doctor. The doctor also has a laptop, and the multi-parameter device is Bluetooth enabled, so by the time the patient goes to the doctor is able to see all the vitals. And if recommended for diagnostics, we provide a cell counter, a semi-auto analyzer, the cell counter for the hematology tests, and the semi-auto analyzer for the biochemistry tests. And those instruments are also Bluetooth enabled, and the doctor is immediately able to see the lab results. And based on that, they are prescribed medicines. We don't get into the medicine part of it, obviously, because the government provides free medicine, and that would not be sustainable for us to do. If the prognosis is more serious, then they are referred to the secondary or tertiary care. Now, the good thing about this is that this has reduced the burden on the tertiary hospitals. So no longer is the PHC just a place to go and, where the doctor touches your forehead and scribbles some medicine and hit or miss kind of diagnostics. It is very evidence-based, and it has now got, in some of the villages in which we are, there is a higher footfall into the primary health center than into the CHC or one of the higher referral hospitals. This is a scene of the Ilaj clinic at North Karnataka. So you see this is the data entry operator, and this is the doctor. So he's putting in all the details there, and he also helps the doctor with his data entry. Sometimes, if the footfall is very high, we give the doctor a separate data entry operator. Then they go to the lab, and the tests are performed, and that's it. Makes a pretty picture. But it really does provide great impact. This is actually in Kaladgi, if any of you are aware of North Karnataka, in Bagalkot district. We're also in Rajasthan, and the blue device that you see on the corner there, that's our multi-parameter device. It's got a tablet, and it's got all these leads, messy leads to all the different instruments. And of course, Rajasthan always makes a prettier picture. Now, the wonderful thing about the Rajasthan program, we were in 5 public health centers here. We are in 15 in Karnataka, plus 3 of our own. This evinced great interest by the IT department in Rajasthan. So we were trying to push it to the medical department. And of course, they are so hassled. They have 3,000 PHCs. And so you come and say, look, we put in a proof of concept in 5. And so they look at us and, are you joking? You're just managing 5 clinics. We are grappling with 3,000. But guess what? Never lose hope. The IT secretary took particular interest in this model, and they worked with us. And today they have implemented a similar electronic medical record system as part of their Integrated Health Management System, IHMS. Some of you may be aware that Rajasthan has a very robust database called the Bhamasha. If you've ever traveled in Rajasthan, you'll see these big hoardings with politicians and Bhamasha. So Bhamasha is essentially their medical insurance platform, which is a very robust database. And into Bhamasha plugs in now their public distribution system, their health, and now they're going to put in all the health records. So now they've launched this IHMS in the clinics in which we had implemented Ilaj, because our staff was already trained and they were accepting of technology. So this is what we were all talking about all morning, that we must have continuum of care. The quality of healthcare becomes standardized. We can monitor disease profile and trigger alerts in case of disease outbreaks. Somebody was asking about that. And the protocols for care delivery are followed automatically, seamlessly, because it's technology. And we have a very good dashboard, which I'll show you later. So we can examine the prevalence of risk factors and initiate preventive health education. And we do generate reports for all the stakeholders at different levels. For example, we give the passwords at different levels. So the medical officer at the clinic can see all the details of his clinic. The district health officer or the chief medical health officer can see all clinics of his district. And the principal secretary health can view the records of all rather the dashboard, not the records, because all this is actually de-identified data. They see only the analytics of the whole state. So that's how we do it. We provide passwords at different levels. Here are some live dashboard details, the hematology tests, the biochemistry tests. Now, why is this important? This looks like such a boring slide, right? Why did I even put it up there? I put this up to remind myself, to tell you that everything isn't a success story. The dashboard is really valuable because then we can see which clinics are using the lab. And for example, we found in one clinic, there was absolutely no usage of the lab devices. So we sent our team there to examine why. And it turns out that the footfall is so high that doctor sees 200 patients a day. And he is in a really remote village. If one person is prescribed a test, everybody in the community will come to know about it, and they will come and demand that they also have all the biochemistry tests done. And he said, how can I manage? How will you manage to support a lab if I have to test every patient? And how will I get through all my patients? And so we deliberated with this with the district health officer. And the district health officer said, please just move the biochemistry machine, the semi-auto analyzer, to the district hospital, because there we will use it much more. We have more lab technicians and so on. So we left the cell counter in the PHC and we moved the semi-auto analyzer to the general hospital. We've done that in now 2 clinics and maybe in 1 more. So that's how this dashboard is useful to us. So when we see the hematology tests, we see that it's up and running. We see the count every day. But with the biochemistry tests, we see that it's flagging. The dashboard also gives us a disease profile analytics. The reason you don't see all the numbers on the pie chart is because when the slice is small, you'll only see the number when you hover your mouse on it. For any of you who are so good in maths that you can quickly add up and say, hey, that doesn't come to 100. Okay. And we also have the top 10 medicine list. And somebody was asking one of the panelists about prediction. Now, prediction can happen only after you've used a system for a number of years. It's like, predicting the weather and whatnot. So we need the data, and we've been in, the Ilaj has been up and running for a little over a year now. So we will have to have it running for a little longer for us to make predictive analytics. Here's the live dashboard, which shows the state-wise patient visit. Gray is Karnataka. This is the Karnataka numbers. Green is Biocon Foundation run clinics. And black is Rajasthan. As I said, Rajasthan had only 5 clinics. In Karnataka, we were in 15. And you may think, hey, you're not doing such a good job after all, because this black line has diminished and then disappeared in June and July. But that's because they shifted to the IHMS software. And they learned a lot from us. Our engineers worked with them to integrate the lab devices, which was the last part which they had to get right. So we're very proud that the black line has disappeared, and I hope that one day the gray line will also disappear. And that would mean that we have truly achieved establishing a proof of concept and getting it up to scale. So within Karnataka, these are the names of the PHCs, and you can see some of them are very tall lines and some of them are very short. The tall lines are in the more remote areas where they don't have any private health care. And the shortest lines are when the doctor hasn't been appointed or the doctor has been transferred. So the clinic is just being maintained by the paramedic staff. But that will improve. Once there's a doctor, automatically all the lines will shoot up. The The third of our flagship programs is the early detection of oral cancer, our Screen and Treat mobile health program. This was completely devised by us and has been running from 2011 very successfully. We have screened many patients since then. Again, you have the quotation. Sorry, I'm very traditional that way. I wonder why. Okay, so here's the thing. In a country like India, we should not let people get terribly sick. We do not have an emergency room to take them to, and we do not have the money to spend on them. So we have to do preventive health care. And for that, we run a lot of tobacco cessation programs, not only on World No Tobacco Day, but at every opportunity that we get. As you know, tobacco is the leading cause of cancer. You may also know that oral cancer is the biggest killer amongst Indian men. And it usually strikes them when they are in the peak of their life, when they are the earning members of the family. And it is no longer restricted to Indian men. It is now permeating into the women as well. And the reasons for this is varied. Of course, in some states, traditionally they chew tobacco. But now in urban centers, where they have become factory workers, they stand in assembly lines, they have long hours to work, whether it's the garment industry or packaging or whatever the industry it is, you find that the women want to finish their work quickly. So they get paid per unit that they either pack or produce. So they want to produce more in a smaller length of time. So you find a lot of them chewing tobacco to assuage their hunger so that they don't have to take lunch breaks. They chew tobacco because there's not much access to clean drinking water, and as long as they're chewing, they don't feel thirsty. And this, my friends, is a big problem amongst all our Paura Karmikas right here in Bangalore. In order to, if you don't segregate your garbage, and if you don't cooperate to make garbage lifting more, easy for them, you are causing severe health problems with the Paura Karmikas of Bangalore. They tell us that they chew just to overcome the smell. And they chew because they have no access to drinking water when they have to do their rounds. So we do massive screening in these kind of communities which are at high risk. So we do population-based screening and opportunistic screening. Opportunistic screening is like the first picture on your left, where this lady has come into the clinic. We set up a desk and we examine everybody who allows themselves to be examined. We examine the mouth and we take a picture of the mouth if they are at high risk, if they are tobacco chewing. Over here, you'll wonder how come the doctor as well as the patient is in a white coat. That's because she's a factory worker. So we go into factories and we do screening. And the last picture here, you can see the sheep in the background. This is the ASHA worker who has gone into the population door-to-door screening. So this is the population-based screening model, and these two are the opportunistic screening models. So the only way to go is early detection, prevention, and then hopefully there hasn't been any lesion detected. If there is, we hope that it's precancerous, in which case the treatment is very affordable and the cure is very quick, and surveillance. There was a warning on the previous slide, which I forgot to accentuate. So these are the lesions that you see here, the red patches, the white patches, and what the ASHA worker does is, these are actual pictures taken by the ASHA workers and sent by the mobile phone to a remote specialist in Bangalore. We have a tie-up with KLE Institute of Dental Sciences, and their specialists actually look at the images, and then they message back to the ASHA worker saying, bring patient number so-and-so to the PHC. When they come to the PHC, there's a lot of advocacy done. They are told about how they have to suspend their chewing or smoking or whatever may have caused the lesion. And we dispense Aquasol, which is a vitamin A, 22 rupees for a bottle of 30 capsules. So over 3 months, all they have to do is open up that capsule of vitamin A and put it onto the lesion. So here you have the ASHA worker in the population-based screening. She identifies the high-risk patients. They go in, actually right there, they ask them sometimes if it's very bad to go into the NCD desk at the PHC. And hopefully they're caught in time and not having to be sent to the tertiary center. In the opportunistic screening model, of course, it's much simpler because we have the patient there and we have the trained healthcare provider right there who has been trained to detect the lesions. So an FHP is a frontline health provider, could be a physician, could be a dentist, could be a nurse, A&M, GNM. So on the left, you see the digital sheet and the digital pen with which they record the survey. But we found that the ASHA workers were losing the sheets, losing the pens, just like you and I do. So we now stick with the mobile health way of going with the survey. These are some pictures of oral lesions and how they're actually taken in the field. And this is the open MRS, which is used to look at each image very carefully and either refer the patient into a clinic if it was in a population-based screening scenario, or in any case, the dentist or the dental surgeon or a physician, anyone who's been trained to identify the lesions can look at it. So this is the workflow, the protocol. We empower the local community health worker, the ASHA worker, with a mobile device. And this is the great thing. They take to the mobile phone so easily, they don't feel threatened by it, so they want to use it. And the other thing is that they feel very important, that they're using technology, so there's absolutely no barrier in training the ASHA workers to use the mobile phone device to screen. If the specialist recommends that it is a mild lesion, we give them the simple, inexpensive chemo prevention, which I was talking about, the vitamin A. If it is moderate or severe, then we have to perform a punch biopsy by a certified surgeon in the referral hospital, and then the referral hospital takes over. But the key to this is for primary detection and early detection so that it doesn't progress. Here's an example of what the lesion looks like. And for those of you, there's a lot of denial in cancer. If any of you are smokers, if any of you chew areca nut or tobacco on a regular basis, I'm not talking about the rural population here, I'm talking to the audience here. Please have your mouth screened, because you will not even, it's asymptomatic, it doesn't hurt. In no way does this lesion cause you any concern, but it can progress into those dreadful tumors that you see before any movie, right? It's a terrible way to start a movie when you see all of that, but then this is how it starts. And if you are caught early, then it can be completely cured. So this goes out to you as the audience. Please get your mouth screened. This is our cost of screening For early diagnosis of oral cancer, the cost per patient of screening will be 58 rupees. But if it's progressed, you know what the costs can be like. All of you are in healthcare or you have an interest in healthcare and you know how exorbitant the costs can get. So this is the need of the hour. That's the second part of the title of what I was supposed to speak about. Social innovation, the need of the hour. So surveillance, a linkage to care, and that is very good if you're in the government system, then the linkage of care becomes seamless. You have to be comprehensive, have a pragmatic approach, be proactive with the community, and then while we were doing all of this, we said, then what? What's next? Is what we're doing still relevant? Are we current? Have we been doing this for too long and technology has gone ahead and we don't know what we're talking about? There's so much happening on the forefront of cancer. So at that time, we approached a number of leaders in the field, and we are very happy to say that they all came forward. If you look at this task force to downstage oral cancer, which was launched in February this year, it's an independent task force, and we have the likes of Dr. G.K. Rath, who's the leading radiation oncologist. We have Pankaj Chaturvedi and Dr. Kumar Prabhash, oncological surgeon and medical oncology specialist. We have Dr. Moni Abraham Kuriakos, who's the director of the Cochin Cancer Research Center. We have Vijay Chandru of Strand Genomics, and Dr. Praveen Birur, who is from the KLES Institute of Dental Sciences and leads our Biocon Foundation oral cancer program. And we are absolutely committed to downstaging oral cancer. We do targeted programs, like on World Health Day, No Tobacco Day. This is in addition to the regular screenings that we do. And we have screened in Rajasthan, we have screened in Karnataka, and now in Nagaland as part of our Northeast initiative. As you all know, the Northeast is a very leading in cancer cases. We conduct training programs for all frontline healthcare providers, starting from doctors, dentists, nurses, and community health workers. And of course, we share our learnings through presentations and publications. And here, I have to say that we also share our data, and data philanthropy is the next big thing. Some of the doctors, I think Dr. Mahajan was talking about it. We need to pool our resources, and we have to share our data, and we're always ready to do that. And we would like to have more platforms on which we can share. So here we are with the last quote, also very pertinent to the theme of today's event. I would like to thank Philips India and all the organizers who took so much trouble to put together this event, which has come out so well, so much learning, so much collaboration. I'd like to thank the panelists, all the speakers who have really enlightened us today, and most of all to the audience to bear with us in the post-lunch session. Thank you.
Thank you so much, ma'am. We request Ms. Sumati Rao to come on stage and hand over the token of appreciation to Ms. Pratima Rao.
I hope that's a multi-parameter device.
But before that, do we have any questions? Yes. A round of applause, ladies and gentlemen. Any questions?
Hi. First of all, many congratulations on the absolute amount of transformative work in primary healthcare in the far-flung areas that Biocon Foundation has taken up. It's really fantastic to know. I just had one small question. The e-large EMR that you're talking about, does it incorporate a clinical decision-making or a support-making protocol as well, which is evidence-based?
Well, it just provides you the dashboard data. It does not have an algorithm.
Okay, okay, all right. Thank you.
I think very impressed to see the level of work that Biocon Foundation is doing. So thank you for
Thank you.
sharing those with us. My question is around something that you mentioned at the beginning of your talk around the sustainability and scalability of grassroots solutions. And what I wanted to see was what are your experiences around making some of these things sustainable and scalable? I mean, of course, it's being funded through the foundation money.
That's right.
But foundation money is only going to take it so far.
Right.
Unless you plug that into the government funding
Absolutely
mechanisms, the government health schemes,
Yes.
or figure out another cost-efficient or sustainable mechanisms
Yes.
that are in the private sector,
Right.
these are not going to scale.
Absolutely.
So what are your thoughts around
Okay.
that? Because I didn't see your presentation cover the sustainability and
Right.
scalability aspects.
So I did mention that the Ilaj program in Rajasthan has been scaled by the government. And that was the initiative from the IT department, not the health department of Rajasthan government. So that has been scaled. They have taken the proof of concept. In Karnataka, they have about many individual initiatives, and they are now trying to consolidate and put it together. Of course, we've had a lot of, the elections came, and it has slowed down the process somewhat, but we hope that we will achieve the same level of success in Karnataka as we did with Rajasthan. When it comes to the oral cancer screening, we are already in talks with the Union Health Secretary, and they have asked us to dovetail this program into the Ayushman Bharat effort. So there's the scaling. In the scaling part of it, then obviously we will, as you see, we are working with the government. So we are training the ASHA workers. And now we are going to train master trainers under the Ayushman Bharat initiative. So that will scale by itself. When it comes to the lake, now that's the big challenge, because the government is very proactive, very appreciative. It's the community which is letting us down. Now the whole thinking has to change within the community. They have to own the place. Even yesterday when I went to inspect the lake, I saw a mother taking her kid home from school, and the kid just was eating something and threw the wrapper there and walked off. Of course, I pulled her back and made her pick it up, but I'm not going to be there all the time, right? So plastic getting into the lake is a big issue. And sewage.
Any more questions?
Thank you so much.
Thank you so much, ma'am. Thank you.